Ventilation is the first of the respiratory processes. Now we need to talk about exchanging gases in the body. Dalton's law of partial pressure says that the total pressure of a mixture of gas is the sum of the pressures exerted by each gas. The pressure exerted by each gas is called its partial pressure, and it's directly proportional to the percentage of that gas in mixture. From now on, we're going to be talking about the partial pressure of gases. Think of this as the percentage of gas in solution. We're going to be talking about diffusion, and remember, molecules move from an area of higher concentration to an area of lower concentration. Now that concentration is going to be expressed as partial pressure. At sea level, our atmosphere is about 79% nitrogen, which means that the partial pressure of nitrogen out of that 760 millimeters is about 597 millimeters. About 21% of our atmosphere is oxygen. Its partial pressure is about 159 millimeters of mercury. At high altitudes, the partial pressures will decrease a little bit because the total atmospheric pressure will be lower. At 10,000 feet above sea level, the partial pressure of oxygen is only about 110 millimeters of mercury. Henry's law is another gas law we need to be aware of. When a gas is in contact with a liquid, the gas will dissolve in the liquid in proportion to its partial pressure. The greater the pressure, the more gas dissolves in the liquid. At equilibrium, the partial pressures in the atmosphere and the liquid are equal. If the atmospheric pressure decreases, then the gas will come out of solution. How much of a gas will dissolve is dependent on the solubility of the gas in the liquid. Carbon dioxide is almost 20 times more soluble than oxygen, and also the temperature of the liquid. The warmer the liquid, the less soluble the gas. Now let's apply this to something that you're familiar with, a bottle of soda. When they put carbon dioxide, which is the gas they put into carbonated beverages, when they put that in, they put it in under high pressure. When you open the lid, you hear that hissing. That's the air changing its pressure. And you'll see the bubbles of the carbon dioxide start to come out of solution because we've changed the pressure over that liquid. If you let that sit for a while, it starts to go flat. More and more carbon dioxide comes out of it. It happens less slowly in the refrigerator, but if you let a soda sit out on the countertop, it becomes flat much quicker. Why? Because the warmer the liquid, the less soluble the gas. Hyperbaric oxygen chambers have a clinical application of Henry's law. Oxygen in these chambers are at pressures greater than 1 atmosphere. This forces a greater than normal amount of oxygen into the blood. It can be used to treat carbon monoxide poisoning. Hemoglobin likes carbon monoxide much more than it likes oxygen. We can also use it to treat tissue damage after radiation therapy, and we use it to treat anaerobic bacterial infections. As you go down below atmospheric pressure, you increase the atmospheres. For every 33 feet you go under sea level, you add an atmosphere of pressure. This means that scuba divers that rise too rapidly from the depths have nitrogen in their blood that starts being released and it bubbles out. This bubbles in the blood is known as the bends. They're treated by being put in high oxygen atmospheres. The atmospheric gas, remember, is about 80% nitrogen, about 20% oxygen. But the alveoli never completely exchange the gas, so there's more carbon dioxide and water vapor in the alveoli than there is in the atmosphere. The gas exchange occurs in the lungs, so there's always going to be more carbon dioxide in the lungs, and then the air has been humidified by the conducting zone. You mix the gases when you inspire air, but you never completely exchange all of the carbon dioxide out of the lungs. The alveolar partial pressures easily change when you change your rate or depth of breathing. External respiration is the gas exchange in the lungs. Oxygen moves into the blood and carbon dioxide moves into the lungs. The partial pressure of the gases and the gas solubilities are responsible for this, as well as the thickness and surface of the respiratory membrane. We also have to worry about ventilation-perfusion coupling, that is, making sure we're matching the alveolar ventilation with the pulmonary blood perfusion. In order for diffusion to occur, there has to be a pressure gradient or a concentration gradient. In the lungs, the PO2, the partial pressure of oxygen, is about 104 millimeters of mercury, and that of carbon dioxide is about 40 millimeters of mercury. In the blood that's coming into the lungs, the pulmonary circuit blood, the PO2, or the partial pressure of the oxygen, is about 40 millimeters of mercury, and that of carbon dioxide is about 45 millimeters of mercury. So you can see we have different concentrations of oxygen and carbon dioxide. The reason that we don't have much of a gradient for the carbon dioxide is because carbon dioxide, remember, is about 20 times more soluble than oxygen. The thickness and the surface area of the respiratory membrane play a role in diffusion. In a healthy person, the membrane is only about a half to 1 nanometer thick. In edematous lungs, lungs that have a lot of fluid in them, the membrane is much thicker. Things like pneumonia and left heart failure will also make it harder to exchange gases. Then there are certain diseases that reduce the surface area of the lungs, things like emphysema, which damages the lung tissue, or blockage of any of the lung tissues because of tumors, mucus, or inflammatory material. Here you can see that the respiratory membrane is only 2 cell layers thick with a very thin basement membrane. Because there is more carbon dioxide in the blood than in the lungs, carbon dioxide will move into the alveoli. Because the oxygen pressure is higher in the alveolus than the blood, oxygen will move into the blood. The ventilation-perfusion coupling has to be a close match. The autoregulatory mechanisms for perfusion of the lungs is the exact opposite to the autoregulatory mechanisms for the tissues. Low oxygen in the alveoli closes the arterioles so that blood is redirected to areas of the lungs with more oxygen. This is just the reverse of the tissue where low oxygen opened the arterioles. High oxygen in the alveoli causes the arterioles to open so that more blood goes there. If there's oxygen there, that's where we want the blood to go. The bronchioles that are servicing the alveoli with high carbon dioxide levels will dilate to allow more air exchange. The changing of the arteriole and the bronchiole diameters synchronize, so blood is always sent to high oxygen alveoli and air exchange increases in high carbon dioxide alveoli. Here you see the mismatch of ventilation and perfusion. If ventilation is low, or perfusion of the alveoli is high, this will not allow for an efficient change. So we decrease the pulmonary arterioles, sending less blood to these alveoli. Over here, ventilation is greater than perfusion. We're going to open up the blood vessels to allow more blood to come to this area where there is more oxygen. Internal respiration is the exchange of gases in the tissue. Oxygen to the tissues and carbon dioxide will go into the blood. Again, partial pressures and gas solubilities play a role, as do the thickness and surface area of the exchange membrane. This will be the membrane of the capillaries. We also have to match perfusion and tissue needs. The partial pressures and the gas solubilities work like this. In blood, the PO2 is about 100 millimeters of mercury, and the PCO2 is about 40 millimeters of mercury. In the tissues, we can't be sure exactly what it is, but we know that the PO2 in the tissues is going to be less than 40 millimeters of mercury, and the PCO2 in the tissues will be greater than 45 millimeters of mercury. Again, we have a fairly steep gradient for oxygen and a less steep gradient for carbon dioxide because carbon dioxide is more soluble than oxygen. You'll remember that the capillary tissue membrane is thin. The capillary is only a single layer of cells. Also, tissue perfusion is driven by tissue need. Where we have an active tissue, there will be low oxygen and high carbon dioxide, will open up the capillaries. Where the tissue is relatively inactive, the oxygen and carbon dioxide levels will more evenly match the blood, and we will close off the capillary bed. Here you see the overview. While inspired air will have quite a bit of oxygen and almost no carbon dioxide, in the alveoli we see a slightly different picture, simply because we never blow all of the carbon dioxide out of the alveoli. The pulmonary arteries are bringing oxygen-poor, carbon dioxide-rich blood in. The exchange will occur, and the pulmonary veins will have oxygen-rich, carbon dioxide-poor blood. This will be taken to the tissues where we have the conditions that allow for oxygen to go into the tissue and carbon dioxide to go into the blood. Since oxygen isn't very soluble in water, only about 1.5% of our oxygen actually travels dissolved in the blood. Most of the oxygen is transported on hemoglobin in the red blood cell as a molecule known as oxyhemoglobin. This is what gives oxygenated blood its bright scarlet appearance. Hemoglobins will hold 4 oxygen molecules. At any given time, our blood is about 98% saturated with oxygen. The more oxygens we get on a hemoglobin, the more the hemoglobin wants to take on oxygen. So if we just have 1 oxygen on the hemoglobin, the second one comes on, the third one comes on a little faster, and the fourth one comes on really fast. At about 70 millimeters of mercury, hemoglobin is fully saturated. So remember, most of the time we have about 100 millimeters of mercury circulating in the blood in terms of the oxygen levels. As oxygen levels decline, oxygen is quickly released by the hemoglobin. This is because of the reduced affinity for oxygen, the less oxygen there is on the hemoglobin. There are other factors that influence hemoglobin saturation. These are temperature, blood pH, and the amount of BPG in the blood. BPG is 2,3-bisphosphoglycerate. This is produced as a byproduct of glucose metabolism. If you increase any of these, oxygen affinity for hemoglobin increases. If you decrease any of them, oxygen affinity for hemoglobin decreases. That is, hemoglobin gives up oxygen easier. In metabolic tissues, the blood is warm. There is a high carbon dioxide concentration, which automatically means there's a low pH, and there's a high BPG. All of these will increase the release of oxygen from hemoglobin. In the lungs, all of these things are lower, so that we increase the binding of oxygen to hemoglobin. We pick up oxygen more readily. Hypoxia is inadequate oxygen delivery to the body tissues. There are several types of hypoxia. Anemic hypoxia occurs when there's not enough hemoglobin to deliver the oxygen. Ischemia or stagnant hypoxia occurs if there's impaired or blocked blood circulation. Histotoxic hypoxia occurs if the oxygen is delivered, but the cells are unable to use oxygen. Metabolic poisons like cyanide damage the cells and do not allow them to use oxygen. Hypoxemia hypoxia is when there's reduced arterial oxygen. This can be as the result of pulmonary disorders, in other words, we can't get air into the lungs, or if there's low oxygen in the atmosphere, for example, if you're at very, very high atmospheric levels. Carbon monoxide poisoning is a unique kind of hypoxia. Carbon monoxide has an affinity for hemoglobin that's 200 times greater than that of oxygen. Therefore, just a little bit of carbon monoxide in the atmosphere will knock oxygen off the hemoglobin. That way, oxygen won't be delivered to the tissues. This is why a hyperbaric chamber is used to treat carbon monoxide poisoning. We have to really force the carbon monoxide off of the hemoglobin by giving it lots and lots of oxygen. All of the hypoxias tend to lead to cyanosis because of the poor oxygenation of the tissues. The exception is carbon monoxide poisoning. Carbon monoxide poisoning makes the blood a bright, bright cherry red, so people who have carbon monoxide poisoning tend to be bright pink. Carbon dioxide is transported in the blood a little differently. It's more soluble, so 7 to 10% travels dissolved in the plasma. About 20% of it will bind to hemoglobin as carboxyhemoglobin. The other 70% travels in the blood as bicarbonate ions. This reaction is the carbonic acid reaction. Carbonic acid is a relatively weak acid. It's made from carbon dioxide and water, and it will dissociate weakly into hydrogen ions and bicarbonate ions. A strong acid will deliver almost all of its hydrogen ions to the solution, but a weak acid will only deliver a few. The more hydrogen ions there are in solution, the more acidic the solution. So because this particular acid does not dissociate completely, it only delivers a few hydrogen ions to the solution, and the rest of the molecule stays as carbonic acid, we have less of a change of pH in the blood. While this reaction can happen in the plasma, it occurs much more rapidly in red blood cells because in the red blood cell we have an enzyme called carbonic anhydrase which causes this reaction to occur. This is the gas exchange in the tissues. In the tissues we have a lot of carbon dioxide which will move into the blood. Some of the carbon dioxide will dissolve in the plasma. Just a little bit of it will go through the carbonic acid cycle. These few hydrogen ions that are produced will attach to plasma proteins so we won't change the blood pH. But most of the carbon dioxide will enter the red blood cell. Some of it will combine with hemoglobin, and that hemoglobin is available because the oxygen was released. Remember, in the tissues we have the low pH and the warmth and the high BPG, all of which alters the affinity hemoglobin has for oxygen, reducing it. So oxygen is released and will travel into the tissues. A little bit of the oxygen was dissolved in the plasma and it will also travel to the tissues. But most of the carbon dioxide will come into the red blood cell and rapidly be converted to bicarbonate ions and hydrogen ions. Now these hydrogen ions will attach to the hemoglobin and that will buffer the hydrogen ions. The bicarbonate ions will leave the red cell, travel in the blood, and because we're taking negative ions out, we'll have to put some negative ions in, so chloride goes in. This is referred to as the chloride shift. Now when we get to the lungs, the reverse happens. That dissolved carbon dioxide goes into the alveoli. We slowly put together some carbonic acid, which breaks down to carbon dioxide and water. But we very rapidly pull bicarbonate ions back into the red blood cell and shift those chloride ions back out and break down the carbonic acid that's produced to carbon dioxide and water. That leaves. Hemoglobin will have the carbon dioxide bumped off of it because in the lung we favor oxygen attaching to hemoglobin. Because so many hydrogen ions have the potential to be released, we could have a problem maintaining blood pH. But the carbonic acid bicarbonate buffer system is a very important system for maintaining blood pH. Because carbon dioxide and water can be made into this weak acid, which just minimally breaks down to hydrogen ions and bicarbonate ions, and they'll go back in the other direction so we can get carbon dioxide, we always have just a small amount of hydrogen ion being produced by this reaction. And you can see that the hydrogen ions either bind to the plasma proteins or they stay in the red blood cell. There are several neural controls of respiration. In the medulla, we have the respiratory centers. There's the ventral respiratory group, or the VRG, and the dorsal respiratory group, or the DRG. The ventral respiratory group is believed to be the rhythm generating and integrative center. The neurons here seem to be involved in inspiration and expiration. There's a group of inspiratory neurons. These travel in the phrenic and intercostal nerves. The phrenic nerve goes to the diaphragm, and they will stimulate muscle contraction in these two muscle groups. The expiratory neurons seem to inhibit the inspiratory neurons, so that the inspiratory neurons are no longer sending a signal. This allows the muscles to relax. The dorsal respiratory group integrates the input from the peripheral stretch and chemoreceptors. They'll communicate this information to the ventral respiratory group, but we don't completely understand this particular control system. Then in the pons, we have the pontine respiratory centers. They influence and modify the activity of the medullary neurons. Again, we're not quite sure what they do, but we think they smooth the transition from inspiration to expiration. So those are relatively smooth. You don't just suddenly inhale and then suddenly exhale, but you kind of have that rhythm of inhale and exhale. There may be some pacemaker neurons in the ventral respiratory group. At least that's one hypothesis for how we generate a rhythm. The most widely accepted hypothesis is that normal rhythm results from the reciprocal inhibition of those interconnected neurons in the medulla. That is, the inspiratory neurons cause the muscles to contract, and then the expiratory neurons inhibit the inspiratory neurons. Breathing rate and depth are controlled by changing body demands. There are chemical factors, the higher brain centers, and reflexes that are involved in this. Chemical influences can be carbon dioxide, pH, and oxygen. There are chemoreceptors for all of these. Some are located in the brain and are called central chemoreceptors. Others are found in the periphery. They're found in the aortic arch and the carotid arteries, and these are called the peripheral chemoreceptors. Of all of the chemoreceptors, the carbon dioxide chemoreceptors are the most influential. Hypercapnia, or excessive carbon dioxide in the blood, causes the formation of carbonic acid. This increases the hydrogen ion concentration in the blood. This will stimulate the central chemoreceptors to increase ventilation. So while carbon dioxide is the initial cause, it's actually the hydrogen ion buildup that stimulates the central chemoreceptors. Hyperventilation is an increase in the rate and depth of breathing to reduce carbon dioxide levels in the blood. Involuntary hyperventilation, caused by anxiety usually, can remove too much carbon dioxide from the blood. This results in hypocapnia, not enough carbon dioxide in the blood, and this will constrict the cerebral blood vessels. As a result, not enough blood will get to the brain and people will experience dizziness, may also experience tingling and muscle spasm. To reverse this process, you usually have them blow into the bags so they rebreathe some carbon dioxide. This helps restore the carbon dioxide levels in the blood to normal. The other chemical influences are oxygen and pH. The oxygen receptors are found in the aortic arch and the carotids. Declining oxygen levels only have a very slight effect on respiratory rate because oxygen levels in the blood have to drop substantially. You have to get below 60 millimeter partial pressure of oxygen in the blood because there's such a huge oxygen reservoir on the hemoglobin. Most of the time our hemoglobin is carrying 3 oxygen molecules on it. So if it drops one and then has to drop a second one, we've got plenty of oxygen. At 60 millimeters of mercury of oxygen, the brainstem is depressed, but the chemoreceptors to oxygen will still stimulate breathing. Hydrogen ions do not cross the blood-brain barrier. The peripheral chemoreceptors can monitor pH. An increased carbon dioxide lowers pH, but so does metabolic activity. There can be metabolic acids that circulate in the blood, so we could have a lowered pH independent of carbon dioxide levels. Again, low pH will increase the respiratory rate so that we can reduce carbon dioxide. Even though the carbon dioxide may not be the source of the acid, we will need to get rid of carbon dioxide to help buffer the blood better. Your higher brain centers can influence your respiratory rhythm. Your hypothalamus and your limbic system are involved in emotions. Strong emotions and pain can cause you to change your rate and depth of breathing. If you're surprised, you will frequently have a sharp intake of breath or a gasp. When you're angry or when you're in pain, you may hold your breath. If there is a rise in body temperature, you tend to increase your rate because you're trying to blow off warm air. And if you're suddenly chilled, you may stop breathing altogether. That's a condition called apnea. At the very least, you'll begin to gasp for breath. Your respiratory muscles are voluntary muscles, so your brain cortex can have some control over them. However, if you try holding your breath for too long, there's a buildup of carbon dioxide that will stimulate the chemoreceptors, and this will override your voluntary control. One of the ways they can tell if someone was alive when they entered the water and drowned is because if they were alive, even though they try to hold their breath, they eventually inhale, and they will inhale water. So finding water in the lungs is an indication that they were alive when they went into the water. There are a couple of reflexes that will affect rate of breathing. One is the pulmonary irritant reflex. You have lung receptors that respond to irritants. These communicate through the vagus nerve, and you'll remember the vagus nerve is part of the parasympathetic system. The parasympathetic system causes bronchial constriction. The idea would be that the irritant would be stopped from entering the lungs so that we would limit damage. Irritants may also stimulate the cough reflex. The inflation reflex pays attention to stretch receptors that are in the pleura and the conductive passages. If these are stretched excessively, the vagus nerve will end inspiration. If they become too quiet, inspiration is initiated. This is the Herring-Brewer reflex. This is not thought to be any kind of regulatory mechanism for inhaling and exhaling, but rather it prevents damage as a result of overstretching of any of the tissues. The respiratory system will make adjustments to help meet the needs of your body. When you start exercising, your working muscles demand large quantities of oxygen. Hyperpnea is the increased ventilation in response to metabolic need. Hyperpnea differs from hyperventilation. With hyperpnea, we're not changing the blood carbon dioxide or oxygen levels. With hyperventilation, we were changing the blood carbon dioxide levels. Exercise hyperpnea is not caused by an increase in CO2 or a decrease in pH or oxygen. There is first of all a sudden increase in breathing rate, then a gradual increase, and then your breathing becomes steady but much deeper as you start taking deeper breaths and moving more air with each breath. The venous gas levels change, but the arterial blood levels remain about the same. The sudden increase may be the result of psychological aspects of exercise. You're thinking about exercising. You're thinking you're going to need to breathe more deeply. As the skeletal muscle becomes activated, we may also get excitatory impulses from the proprioceptors in the joints. The plateau of breathing will reflect the rate of carbon dioxide delivery to the lungs. Another respiratory adjustment is the one to high altitude. Most people live between sea level and 8,000 feet, and there are no real problems if you slowly change your level of altitude. But if there's a sudden change, you may experience acute mountain sickness. Acute mountain sickness has the symptoms of headache, shortness of breath, nausea, and dizziness. This is sometimes seen in ski resorts where people may jet in and very suddenly find themselves in a higher atmosphere and immediately begin rather vigorous exercise. In severe cases, it can lead to lethal pulmonary and cerebral edema. If there is a long-term change, in other words, you move to an area of a higher altitude, your body will make respiratory and hematopoietic changes. This is called acclimatization. You will develop more red blood cells, you'll develop more pulmonary capillaries, and your chemoreceptors will become more responsive to increased in carbon dioxide. You'll actually change your tidal volume a little bit. You'll breathe more deeply. Lung diseases are a major cause of disability and death in North America. Some of the most disabling of the lung diseases are chronic obstructive pulmonary diseases, or COPD, asthma, tuberculosis, and lung cancer. Both COPD and lung cancer have very strong links to smoking. In COPD, our best examples are emphysema and chronic bronchitis. COPD is an irreversible decrease in the ability to force air out of the lungs. About 80% of people with COPD have a history of smoking. They experience dyspnea, or difficult or labored breathing. They're said to have air hunger. They can't get enough air, and this steadily progresses throughout life. They have coughing and frequent pulmonary infections, and most develop respiratory failure that's manifested as hypoventilation, that is, an insufficient ventilation to support metabolic needs. They retain carbon dioxide. As a result, they have blood acidosis and hypoxia. Emphysema is one of the diseases that is classified as COPD. In emphysema, there's a permanent enlargement of the alveoli and destruction of adjacent alveolar walls. The lungs lose their elasticity. As a result, the accessory muscles of the chest are recruited to ventilate. This requires a lot of energy. These people are tired all the time because they expend so much energy just trying to pull air into their lungs. Their bronchioles will open during inspiration, but for some reason we don't totally understand, they collapse during expiration. So air is trapped in the alveoli, and this leads to hyperventilation. This gives them what's sometimes called a barrel chest because their lungs are overinflated all the time. There will be damage to the pulmonary capillaries and increased resistance in the pulmonary circuit. Since there's increased resistance in the pulmonary circuit, that means the right ventricle is working harder, so it becomes overworked and enlarges. Smoking contributes to emphysema, but there are hereditary factors. Some people get emphysema and never smoke. There is, for example, a deficiency in a gene called alpha-1 antitrypsin. This is an enzyme necessary to keep the lungs healthy, and some people have this gene absent and can't produce this protein. The other example of COPD is chronic bronchitis. Inhaled irritants lead to a chronic production of excessive mucus in the respiratory system. The lower respiratory pathways become inflamed, and as a result of this inflammation, they develop quite a bit of scar tissue or fibrotic tissue. The airway becomes obstructed, so the lungs can't ventilate well, and if they can't ventilate, there can't be gas exchange. Pulmonary infections are frequent because there's so much mucus, and the mucus is an excellent growth medium for bacteria. Smoking is one of the irritants that may cause chronic bronchitis, as well as environmental pollutants. With COPD, there are two different patterns of symptoms. They're what we call the pink puffers. They work hard to maintain adequate ventilation. As a result, they're spending so much energy ventilating that they lose weight. Typically, pink puffers are associated with emphysema. The blue bloaters tend to have a stocky build and they're hypoxic, so they're cyanotic. That's why they look blue. The hypoxia causes pulmonary hypertension, right side heart failure, and this is typically associated with chronic bronchitis. Now, these two things are seldom this clear cut, but you do hear people talk about pink puffers and blue bloaters. To treat COPD, you can use bronchodilators and corticosteroids. As the disease progresses, oxygen use is employed. Some people are candidates for lung volume reduction surgery. You'll remember that the lungs have those walled off segments. In this case, we can take a few segments out. It allows the remaining segments to expand more fully. This does not lengthen life, but it does improve the quality of life. When you are administering oxygen to people with COPD, you have to be careful because you can shut down their respiratory mechanisms. When they are in acute distress, the first thing you want to do is slap oxygen on them. But if you give them too much oxygen, then their alveoli fill with oxygen. This will constrict the bronchioles because bronchioles constrict going to oxygen-rich alveoli. That means that they will stop breathing. Asthma is another one of the lung diseases. Asthma is seen as episodes of coughing, difficulty breathing, wheezing, and chest tightness. It's believed to be caused by bronchospasms that are triggered by cold, exercise, or allergens. Unlike chronic obstructive pulmonary disease, asthma does not worsen over time. When these people are having an asthma attack, they have a sense of panic. Their bronchioles constrict and they just can't move air. Allergic asthma is the most common kind of asthma. Here the allergen triggers an airway inflammation first rather than a bronchospasm first. The inflammation persists even in the absence of the allergen, so the airways are hypersensitive to anything coming in. Most allergens that trigger asthma are very common. Dust mites, animal fur, fungi, things that are pretty much impossible to remove from the person's lifestyle. Once the airway walls are thickened with inflammatory exudate, any bronchospasms that occur are magnified. Most cases are in children, and the number of cases are increasing. This could be, as we talked about, in the immune system, because we don't allow children to be exposed to enough things early in life, and their immune system becomes overly sensitive. Treatment is usually with fast-acting bronchodilators to treat the immediate symptoms. Inhaled corticosteroids may treat the underlying inflammation. Tuberculosis is an infectious disease that's caused by the microorganism Mycobacterium tuberculosis. This is a bacteria. This is a truly airborne disease. You can get it by inhaling air exhaled by someone with tuberculosis. About 1/3 of the population of North America is infected with tuberculosis, but most will not develop an active case of TB. Your immune system responds to the primary infectious agent by walling it off and causing tubercles in the lungs. These are little fibrous or calcified nodules. The bacteria can survive in the nodules, and if the nodules break down, then they can become infectious. Most people's immune system stays strong enough to keep the nodules intact. There are some drug-resistant strains, probably because treatment for some people has been incomplete or inadequate. Tuberculosis is typically a disease of the poor. Crowding conditions allows the disease to spread quickly, and among the homeless there's an inability to follow treatment. The The homeless move from place to place trying to follow the best weather. The treatment for tuberculosis is 9 months to a year and a half of antibiotics. It's very hard for someone who's moving from place to place to maintain that kind of regimen. Lung cancer is the leading cause of deaths in men and women in North America. 90% of the cases of lung cancer can be linked directly to smoking. The cure rate for lung cancer is notoriously low. Lung cancers are aggressive, they metastasize readily, and they're usually undiagnosed until they are well advanced. The 5-year survival rate for lung cancer is 17%. There are 3 major types of lung cancer. Adenocarcinoma, which accounts for about 40% of lung cancers, is from damage to cells in the peripheral lung areas. Squamous cell carcinoma, which accounts for 25 to 30% of the lung cancer, arises from the epithelium of the bronchi. Small cell carcinoma, which accounts for about 20% of lung cancers, originate in the main bronchi. These are the most aggressive of the cancer cells. They grow aggressively in the mediastinum, they metastasize readily, and they may secrete hormones like ADH and ACTH. The respiratory system is sufficiently developed by 28 weeks for a newborn to live outside of the uterus. At that point, there is usually a sufficient amount of surfactant so that if the lungs are inflated, they will stay inflated. The first breath of the infant is triggered by a carbon dioxide buildup in the blood. Cystic fibrosis is the most common lethal genetic disease in North America. People with cystic fibrosis secrete an abnormally thick mucus which blocks the airway. They're also subject to Pseudomonas aeruginosa infections. The treatment has typically been using mucus-dissolving drugs and doing a system called clapping regularly 3 or 4 times a day. You beat the back of their chest to break up the mucus so that the mucus can be expelled from the body. Also, they take antibiotics to try to prevent infections. Lung transplants are typically used to treat this disease, and now they are working on gene therapy, trying to put the correct gene into enough cells that they will produce the appropriate enzyme and be able to make thinner mucus. As you age, your respiratory rate changes. In newborns, respiratory rates are between 40 and 80 breaths per minute. In adults, it's about 12 to 16 breaths per minute. Often this increases with aging. At birth, only 1/6 of the alveoli expand. During your first few years of life, they continue to expand, and usually the full expansion of the lungs is completed by the age of 25. If you begin smoking before the lungs are fully developed, you will stop the maturation in that point. In other words, teenagers who start smoking never develop their lungs fully. The maximum amount of oxygen used during aerobic metabolism is called the VO2 max. This declines about 9% per decade starting at age 20 in inactive people. If people remain active, it declines less, but it does still decline. Also, as we age, there's a loss of compliance of tissue. The thoracic wall becomes more rigid. This is largely because the costal cartilage becomes less flexible, so it's harder to expand the chest wall. Also, lungs tend to lose their elasticity. Other changes that occur with aging includes a decline in vital capacity. Your vital capacity is about 1/3 less by the time you're age 70. Blood oxygen levels will decline slightly. The elderly tend to become a little hypoxic during sleep and may experience sleep apnea. There are fewer mucus glands and they secrete a thicker mucus, so there may be more problems with blockage of parts of the lungs. The mucosal cilia become a little less active, and the lung macrophages become a little more sluggish. Both of these put elderly people at a greater risk for infection.